Good evening, students. I'm audible and visible to all of you. Please update me in the chat box. Good evening, everyone. So, welcome to the session, guys. In this session, we are going to have a quick and concise revision for the PSM. And same manner, we'll take this revision with a test and discussion manner. We'll solve some questions. Followed by that, we'll go into the deep discussion of that particular topic. So, without any further delay, let's begin with the first question of the day from the chapter vaccinations. So the first question is, a 14-month-old child is brought up for the first immunization. Which of the following vaccines should be omitted because the maximum permissible age for the administration has been crossed? So this is the question from a delayed vaccination schedule. This is the question from the delayed vaccination schedule. That means that if a patient or if a newborn baby is coming for the first immunization, he's coming for the first immunization at 14 months. So that means he has already missed some vaccines. So which of the following vaccines you will not give because the time period for that vaccine is gone? So if you remember from your primary notes, we have already discussed about the delayed vaccination schedule. So we remember that what are the vaccines that can be given up to 1 year? Very good. So we can give BCG vaccine up to 1 year. We can give PCV vaccine up to 1 year. We can give OPV vaccine up to 1 year. We can give IPV as per the 1 year, and the pentavalent first dose up to 1 year. OPV we can give up to 5 years. Now let's discuss first. Now BCG vaccine we can give up to 1 year. BCG vaccine we can give up to 1 year. Next to that, Rota vaccine, it can also be given up to 1 year. IPV, it can be given up to 1 year. PCV vaccine, it can be given up to 1 year. And pentavalent first dose can be given up to 1 year. Now, all these vaccines can be given only up to 1 year. So the question was 14 months. So it is more than a year. So which of the following vaccines should be omitted because the maximum permissible age has been crossed? Your answer is going to be BCG vaccine. Your answer is going to be BCG vaccine because BCG vaccine can be only given up to 1 year. Now let's talk about the other vaccines. If I talk about the pentavalent second and third dose, so this vaccine can be given up to 7 years. This can be given up to 7 years. Next to that, OPV, it can be given up to 5 years. OPV can be given up to 5 years. Next to that, measles, mumps and rubella, it can be given up to 5 years. DPT, it can be given up to 7 years. And the last one, Japanese encephalitis, it can be given up to 15 years. It can be given up to 15 years. So simple question was asked that which of the following vaccine will be omitted on the first immunization, and that is going to be a BCG vaccine. Okay. Now one more question I will add on here. Can you let me know about the side effect of these vaccines? If I talk about the measles vaccine, what is going to be the side effect of the measles vaccine? Write down in the chat box. Very good, sir. It is going to be thrombocytopenia. Measles vaccine can cause thrombocytopenia. Okay. Next to that, if I talk about OPV vaccine, oral polio vaccine, so it can lead to the paralysis. It can lead to the paralysis. DPT vaccine, pertussis mainly, it can cause persistent crying as an adverse effect. Persistent crying. And if we talk about BCG vaccine, it can cause scar lymphadenitis. Scar lymphadenitis. So these are also the side effects of the particular vaccines. Now, in a clinical case, it's given that post-vaccination, you are on the examination, you are seeing there is a sausage-shaped lump. So sausage-shaped lump is your diagnosis goes to the red currant jelly stools with a sausage-shaped lump. You think of an intersusception. So intersusception is going to be the side effect for Very good. Interception is going to be side effect for, that is going to be side effect of rota vaccine. That is going to be side effect for rota vaccine. Okay. And one more, one more. Tell me, guys. GBS, Guillain-Barré syndrome, is going to be the side effect for which vaccine? GBS. It is caused by killed influenza. It's a side effect of killed influenza. So this is all about, this is all about the side effect of these vaccine. This is all about the side effect of these vaccine. Clear? Yes. Can we move to the next question, guys? Very good. Chalo. Now, if we talk about the universal immunization program, now at what period of time what vaccines should be given? At what period of time what vaccine should be given? Now, at birth, what are the vaccines given? Sir, it is, remember, as Bob. So what is Bob? It's going to be BCG, it's going to be OPV, and it is going to be hepatitis B. So BCG, OPV, and Hep B should be given on at the day of birth. Okay, followed by that 6 weeks, 10 weeks, and 14 weeks. How do we remember? We remember, first we give OPV1, OPV2, and OPV3. Followed by that, at 6 weeks, we also give Rota 1 and pentavalent 1. We give fractionated IPV1 and PCV1. So at 6 weeks, what are the vaccines we are giving? OPV1, Rota 1, pentavalent, going to include 5 vaccines, D, P, T, Hib, and Hep, fractionated IVP, and PCV1. Around 10 weeks, what are we giving? OPV2, followed by that Rota 2, followed by that we have pentavalent 2. At 14 weeks, we are giving OPV3, we have Rota 3, we have pentavalent 3, and second for the fractionated IPV and PCV2. So these are the vaccines which can be given. These are the vaccines which can be given at 6 weeks, 10 weeks, and 14 weeks. Now, if we talk about 9 months, we are giving measles, MR1, we are giving vitamin A, we are giving PCV booster, fractionated IPV3, and Japanese encephalitis 1, Then 16 to 24 months, we'll give MR2, we'll give DPT first booster, we'll give OPV booster dose, and we'll give Japanese encephalitis 2. Clear? And at 5 years, we are going to give DPT second booster. And 10 to 16 years, T. Is that clear? So that is all about universal immunization program. Okay. Now, in a quick manner, let's discuss about the vaccine strains as well. So for the measles, it's going to be Edmonds or Zagreb. Okay. For the yellow fever, it's going to be 17D. You already remember that. For mumps, it's going to be Geralin. Okay. For rubella, it's going to be RA273. For influenza, it's going to be A72009 Caliph. Okay. Then we have Salk and Sabin for IPV and OPV. And we have Nakayama SA14142 for Japanese encephalitis live and killed. And for the BCG, it's going to be Danish 1331. So that's all about the chapter vaccination you have to remember. But make sure you remember more about the side effects, first thing, and about the delayed vaccination schedule. Remember, sterile water is going to be the diluent for? That is for MMR. Okay. Phosphate saline buffer. That is going to be Japanese encephalitis. Then for the yellow fever, dengue, okay, and BCG, it's going to be normal saline. So that's all about the first question of the day from the vaccination. Let's go with the next question. A 45-year-old man with a 10-year history of smoking visits a health camp. He has no respiratory symptoms. He is advised to stop smoking and is counseled regarding the lifestyle modification to prevent the development of COPD. Now, which level of prevention is being applied in this scenario? So write down in the chat box which. Now, a 45-year-old man with a 10-year history of smoking, that means this factor is present, but currently he has no respiratory symptoms. So currently he has no disease. Now we are trying to make understand that you should stop the smoking, go for the lifestyle modification so that you prevent the disease from occurring. So in presence of a risk factor, when you prevent the disease, that is going to be the which level of prevention? Very good, excellent. That is going to be the primary level of prevention. That is going to be the primary level of prevention. Okay. Now, if we talk about the level of preventions before the disease, we have a pre-pathogenic phase. Before the disease, we have pre-pathogenic phase, and after the disease, we have pathogenic phase. After the disease, we have pathogenic phase. In pre-pathogenic phase, prior to the disease, we can go with a primordial. We can go with a primordial level of prevention, and we can go with a primary level of prevention. We can go with a primordial level of prevention, and we can go with a primary level of prevention. Now, once the disease has been occurred, we can go with a secondary level of prevention, and we can go with tertiary level of prevention. Then pathogenic phase mein we have secondary level of prevention and tertiary level of prevention. Now let's discuss each of the following, because it is important to remember what exactly each type means. It's not like that you remember with the examples like, okay, mammography is going to be a secondary, vaccines are going to be primary. Okay, so let's understand the concept first. So if we talk about the first very one, that is going to be a primordial level of prevention. Primordial level of prevention simply means that you stop or you prevent the risk factor from occurring. Okay, so when you stop the risk factor from the occurrence, that is going to be a primordial level of prevention. Now, what is going to be the primary level of prevention? Now the risk factor is present, you are trying to stop the disease to occur. So in presence of risk factor, you are preventing the disease. That is going to be primary. Followed by that, now disease is present, that next one is going to be the secondary level of prevention. So early diagnosis and treatment, that is going to be a secondary level of prevention. Then next one, management of the complications and disability, that is going to be a tertiary level of prevention. That is going to be a tertiary level of prevention. Now let's understand each of the following. What is primordial? So it simply means prevention of occurrence of risk factor. Prevention of occurrence of risk factor. That is going to be the primordial level of prevention. That is going to be the primordial level of prevention. For example, you are encouraging the kids for the outdoor activities. You are encouraging the kids for the outdoor activities. Second example, if you are changing the water of the cooler every week so that mosquitoes will not come, so you are preventing the risk factor to occur, because mosquitoes are going to be risk factor for the malaria. So changing this water every week is going to be a primordial level of prevention. Now next to that, primary level of prevention. What is primary level of prevention? That is prevention of disease in presence of risk factor. In presence of risk factor. Now what if the mosquitoes are in the room? Now you're preventing yourself from the mosquito bite, so you're using these mosquito nets. So these mosquito nets are going to be the which level of prevention? They are going to be a primary level of prevention. They are going to be the primary level of prevention. Is that clear? Now next to that it's going to be a secondary level of prevention. Now what if you got a mosquito bite? Now you're going to hospital for the rapid tests like HRP2 or the LDH test. So early diagnosis and treatment is going to be a secondary. Early diagnosis and treatment, it's going to be the secondary level of prevention. Early diagnosis and treatment, it's going to be a secondary level of prevention. Then what exactly is a tertiary level of prevention? Tertiary level of prevention means management of complications, management of complications and disability. So what is the classical example for that, sir? Clutches in the polio. Clutches in the polio. So this is all about the primary level, primordial, secondary and tertiary. Now if we talk about phases, primordial and primary, it is going to be pre-pathogenic. It's going to be a pre-pathogenic. And secondary and tertiary, secondary is going to be early pathogenic. And this is going to be late pathogenic. Tertiary is going to be the late pathogenic. Okay, now simple examples. Vaccines are going to be which level of prevention? Very good. Vaccines are going to be primary level of prevention. Okay, now all the vaccines are going to be the primary level of prevention. Now in case the question mentioned that BCG vaccine in view of treatment for the bladder cancer, that time you're using that BCG vaccine as a treatment, so that goes with a secondary level of prevention. That goes with the secondary level of prevention. Now pap smear, all the screening tests, they are going to be the secondary level of prevention. They are going to be the secondary level of prevention. Mammography, this is going to be the secondary level of prevention. Change of the water in the cooler every week, that is going to be the primordial level of prevention. And if use of mosquito nets, that is going to be the in presence of risk factor, you're preventing the disease, that is going to be the primary level of prevention. That is going to be the primary level of prevention. Is that clear? That is going to be the primary level of prevention. So that's all about the level of prevention. That is all about the second topic, level of prevention. Now, next question from the indicators of the quality life. So which of the following is true about the PQLI, that is physical quality of life index? Which of the following is true about PQLI? So tell me, what are the components? So we have indicators of the quality of life, that is going to be a physical quality of life index and human developmental index, HDI. So which among the following is true about PQLI? So write down in the chat box. Which among following is correct about? Yes, very good. You're right, guys. It's going to be life expectancy at 1 year of age, infant mortality rate, and literacy rate. Guys, this question has been asked multiple times in your exams, and it's a PYQ from the NEET PG as well. So let's understand. We have indicators of the quality of life. Now, first indicator, we have a physical quality of life index. Second, we have human developmental index. Okay, we have global hunger index as well. So let's understand first what are the components of a PQLI. Number first component is going to be life expectancy. Number first one is going to be life expectancy at 1 year of age. At 1 year of age. Okay, followed by that next one is going to be the literacy rate. Next one is going to be the literacy rate. Next one is going to be the literacy rate. And the third one, that's going to be infant. Third one, that's going to be infant mortality rate. The third one, that's going to be infant mortality rate. So we have three components: life expectancy at 1 year of age, literacy rate, and infant mortality rate. The range of the PQLI, is going to be 0 to 100, and the value around is 71. The value around is 71. Clear to everybody? Now, what are the three components of HDI? Number first one, that's going to be life expectancy at birth. We have life expectancy at birth. Followed by that, we have knowledge. And third, that is going to be income. And the range is from 0 to 1, and value is around 0.645. 0.645. What exactly is important to remember? That is going to be the components of these three, and they will ask the same question: which of the following correctly defines PQLI, or which of the following is not included in the PQLI or HDI? Okay, now one of the best countries that have developed these PQLI and other things, that is going to be Norway. Okay, now literacy rate is known by the different names or different synonyms. What are the other names for literacy rate? Number first one is going to be knowledge. Okay, or mean year of schooling. Mean year of schooling, or education index. Or we have education index. So we have mean year of schooling, knowledge, or education index. Next to that, what are the other indicators we have for the quality of life? We have human poverty index. We have human suffering index. And we have multi-dimensional poverty index. Multi-dimensional poverty index. So this is all about the PQLI and HDI. Is that clear? So what correctly defines the PQLI? Life expectancy at 1 year of age, infant mortality rate, and literacy rate. And literacy rate, it can be given as an other option like knowledge, mean year of schooling, or educational index. Clear to everybody? Yes. Now let's move to the next question. Now, which of the following is correct order of the family cycle? Which of the following is going to be the correct order of a family cycle? Yeah, income will come in HDI. Okay, income will come in HDI. Chalo. What is the correct order of a family cycle? Now you remember that family has different phases. So we have 6 phases of the family cycle, from the formation till the dissolution. Now this correct order questions has been asked repeatedly in the NEET PG exams as well. They have asked the correct sequence of the disaster cycle. Number first thing, they have asked correct cycle of the demographic cycle as well. So these two sequence they have asked. So they might can ask the correct order or the sequence of the family cycle as well. Okay. Now yes, everybody is right in the chat box. It's going to be option B, that is going to be formation, extension, then complete extension, then contraction, followed by complete contraction, and the dissolution. Okay. Now sir, families are not constant, they are ever changing, and they have 6 phases. The first phase is going to be the formation, which begins from the marriage to the birth of the first child. Followed by that, we have extension, that is birth of the first child to the birth of the last child. Followed by that, we have complete extension, birth of the last child, first child leaves home. We have contraction, now family starts to shrink, first child leaves home, then the last child leaves home. Then followed by that, we have a complete contraction, last child leaves with the first spouse dies, and then the dissolution, first spouse dies with the death of the survivor, So these are all about the 6 phases of the family cycle. Now my question to you guys is that the couple recently married and they have the birth of their first child. Now they enter into which phase? There is a couple, okay, they recently got married and they have birth of first child. Now they enter into which phase? If the question says they enter into which phase? They enter into which phase? What will be your answer? Your answer is going to be they enter into extension. They enter into extension. If the same question says they are in which phase? They are in which phase? Then your answer is going to be, sir, they are in the formation. They are in the formation. Are you getting my point? If I say they enter into which phase, if I say they enter into which phase, it's going to be extension, because just after the birth of the first child, they enter into the extension. Okay, but currently they are in which phase? Okay, from the married, it's going to be the formation. It's going to be the formation. Clear? Now, next question from the epidemiology. Okay, clear to everybody? Speed is okay. Now, next question. A researcher conducts a telephone survey of 100 adults. During a single interview, each participant is asked whether they exercise regularly and whether they have currently any disease like coronary artery disease. What is the most appropriate study design? What is the most appropriate study design? Tell me the answer. What is the most correctly order, or what is the most appropriate study design?
Hello, bhai. How are you? So I just finished my class and I said Dr. Talib will be taking session. So I came to just meet you all and say best of luck for your classes. Okay. So are they answering?
Yes, sir. Sure.
That's very, very good. Okay. So basic idea is we'll be starting super expected from tomorrow. Okay, and we have done all the 19 subject from the faculties and by me also. And from tomorrow onward, we'll be starting that. Okay, and I'll be very happy to see you all in the class. Do watch it and just give your best. Baki PSM mein, what are the final advice to all the students? PSM.
Final advice is go with the updates that I have included in this session. Okay, and rest all the topics that are regularly coming, like vaccinations, BMW, or concept of the health and disease indicators. Focus on that, but we have to focus on the updates as well. Stress a little bit of PSM always comes a little out of the box, but we have to answer the right questions, whatever we have studied. So do not let those questions to go wrong.
So you continue, okay?
Yes, sir. Thank you, sir. Thank you. Thank you for
the
the
best
time,
luck,
sir.
okay?
So let's continue with the same question, guys. Most of you are correct. Everybody is right. A researcher conducts a telephone survey of 100 adults. During a single interview, each participant is asked whether they exercise regularly or whether they currently have or have ever had a coronary artery disease. What is the most appropriate study design? Very good. It's going to be a cross-sectional study. It's going to be a cross-sectional study. Why? Because both exposure as well as disease status are being compared, are being assessed at the same time. So when you compare or assess the both exposure as well as the disease at the same time, that is going to be the cross-sectional study. That is going to be the cross-sectional study. Now let's understand about the different types of study. As we know, we have, first of all, we do the formation of the hypothesis with the help of a time, place, and person. Followed by that, we test this hypothesis. And what are the studies that we use to test these hypotheses? We have first very one, cohort study. Followed by that, we have next one, that is going to be a cross-sectional study. Then we have case control study, and we have a ecological study. Okay, now if we talk about the first study, that is going to be a cohort study. Remember this cohort study, so it is going to be the forward-looking study. Just a short points. It's going to be a forward-looking study, or it's going to be the risk factor to disease study. What we call it as risk factor to disease study. Now, for example, what is going to be the risk factor? Risk factor, for example, if it is a smoking. Now, from the smoking, we'll wait till the lung cancer. So, from a risk factor to disease, what our study we are doing, that is going to be a cohort study, or it is also called as cause to effect study. It's also called as cause to effect study. Okay, now the question that can be asked, you already know that cohort study, sir, from risk factor to the disease, it is going to be the time consuming study, because you have to follow up continuously for this group that whether they develop a disease or not. Clear? Now if I talk about the cohort study, the characteristics is that it's expensive, first one. Followed by that, it's time consuming. it's time consuming, and we need follow-up for the study, very good. Now next to that is, sir, that the calculation question they can ask from this is going to be strength of association is given by, it's given by relative risk, attributable risk, and population attributable risk. So how exactly we calculate the strength of association? What exactly is meant by the strength of association? That means whether the risk factor is involved with the disease or not. So I am saying these 5 people are smokers, and I'm saying smoking causes lung cancer. Now after 10 years I'm going to check whether they have developed the lung cancer or not. So I will check the relative risk, that is incidence in exposed by incidence in non-exposed. So you have 5 people exposed group, 5 people non-exposed group. Then I'll be calculating the relative risk, and in case the relative risk comes more than 1, that means risk factor is associated with the disease. In case the relative risk is equal to 1, sir, there is no association of the risk factor. If it comes less than 1, that means the risk factor is going to be protective. That means smoking does not cause a lung cancer, it rather prevents the lung cancer. So that is what the result of a relative risk. So let's solve the question based upon the relative risk and get an idea. Okay, now a study was conducted to assess the association between the smoking and the lung cancer, and the following data was calculated. Now you have an exposed group, that is smokers, and you have a non-exposed group. So exposed, smokers, and you have non-exposed group, So out of exposed group, 400 people, 80 developed the cancer, and among the non-exposed group, 620 developed the lung cancer. So let's put on the formula for the relative risk. What is going to be the formula? It is incidence in exposed. It is going to be incidence in exposed by incidence in non-exposed. Very good. Now how to calculate the incidence in exposed? It is going to be 80 by 400. It's going to be 80 by 400. And what is going to be incidence in non-exposed? It's going to be 20 by 600. Now let's solve this. 80 by 400 and 20 by 600. So 80 by 400, it is going to be around 0.2, and 20 by 600, it's going to be around 0.03. So what is going to be the answer? It's going to be 6. It is going to be the 6. Okay, so can I say that people who are being smoking, people or the smokers, have 6 times more chances of developing the lung cancer compared to the non-smokers? Clear that? Yes. So simple question, incidence in exposed. So incidence in exposed is 80 by 400. Incidence is non-exposed, 20 by 600. That gives you a correct answer. That is going to be 6. Okay. So what is the interpretation of this particular answer? So that means chances of developing the lung cancer is 6 times more in the smokers compared to the non-smokers. Okay, now interpretation also, that is going to be 6 if relative risk is equal to 1, if relative risk is less than 1, if relative risk is more than 1. Now if relative risk is equal to 1, that means there is no association of risk factor. For example, 5 people were smokers, 5 were non-smokers, right? Among 5, only 1 developed cancer. Among 5, only 1 developed cancer. So relative risk incidence by exposed by non-exposed, it turns out to be 1. That means smoking has no connection with the lung cancer. If the relative risk comes out to be less than 1, smokers 5 people, non-smokers 5 people. Smokers, none of them develop the lung cancer. Non-smokers, 2 of them develop the lung cancer. Are you getting my point? Yes, that means smoking turns out to be protective for the people who were exposed, right? So less than 1, this is called as negative association. This is going to be a negative association. That means risk factor is protective. Good. Now if in case the relative risk is more than 1, if in case the relative risk is more than 1. That's what we have calculated in the previous question. That means there is an association of risk factor. That means there is an association of the risk factor. So RR is equal to 1, less than 1, and more than 1. Clear to everybody? So that's all about the relative risk. Same will be the interpretation of the odds ratio or the cross product ratio that we calculate in case of a case control study. And case control study, it's going to be the opposite. It is going to be the opposite of the cohort study. So if cohort is a forward looking study, this is going to be backward study. This is going to be backward study. If this is risk factor to disease, this is going to be disease to risk factor. This is cause to effect study. This is going to be effect to cause study. This is going to be expensive and time consuming. This is cheap and fast study. Here we need a follow-up in case of a cohort study, and here no follow-up is needed. No follow-up is needed. And sir, the strength of association here, it's given by relative risk, while as in case control, it's given by odds ratio, which is also called as cross product ratio. Which is also called as cross product ratio. So cohort study also, it is a prospective study, while as case control, it is a retrospective study. It is a retrospective study. Okay. And how do we calculate the odds ratio? Yes, odds ratio कैसे calculate करते हैं? Same table, then A into D by B into C. Okay, disease exposure and the disease present, non-exposure and the disease present and absent. Now then we have a cross-sectional study. So cross-sectional study, guys, this is a forward direction, this is a backward direction, but cross-sectional study, it is done at point. It is done at point. It is also called as snapshot study. क्या बोलते हैं इसको? Snapshot study. And it does not calculate a odds ratio or the relative risk. Rather, it tells me about the prevalence. It tells me about the prevalence. Okay, that is about the cross-sectional study. Okay, that is new plus old at one point of time. Then we have an ecological study as well. Ecological study is also done at point, and this ecological study usually is done for the nutritional surveys. Okay, for example, average fat intake in the population, right? And which tells me about the characteristic of the population. That tells me about the characteristic of population. That is all about the different types of studies. That is all about the different studies. Clear? Yes? Sure. Very good. Now let's move to the next question. A 70-year-old retired construction worker presents with a dyspnea and weight loss. Presents with dyspnea and the weight loss. He has a history of asbestos exposure. A chest X-ray reveals there is a pleural thickening and the mass in the lower lung zone. What is the most concerning diagnosis? What is going to be the most concerning diagnosis? So you have a patient, a 70-year-old retired construction worker. He's coming with dyspnea and the weight loss. He has a history of asbestos exposure. Yes. Now the chest X-ray shows there is a pleural thickening and the mass in the lower lung zone. So don't mark a silly mistake. Yes, he had an exposure of an asbestos. That does not mean asbestosis. Rather than that, we have the pleural thickening. That means the pleura is thick with the mass in the lower lung zone. Mass is concerning of a malignancy, and he had also weight loss. So which cancer? Very good. It is going to be D, mesothelioma. Very good. It's going to be D, mesothelioma. Now let's discuss about the different types of a pneumoconiosis. Now what exactly is a pneumoconiosis? So pneumoconiosis means these are the respiratory diseases. Pneumoconiosis, these are the respiratory disease occur due to exposure to dust. Occurs due to exposure to dust. Now let's understand the different types of the pneumoconiosis. Okay, different types of the pneumoconiosis. Yes, we have the Ferguson bodies seen with the asbestosis, and ferruginous means there is ferrous iron, and iron means which stain? Very good, it is Prussian blue stain. Okay, very good. Chalo. Now first of all, the first very one that we are going to discuss is silicosis. Now silicosis, first of all, sir will write in the short format. It's going to be the most common type of the pneumoconiosis, number first. Number second, it's due to the exposure to the stone dust. Next to that, sir, silicosis, the patients are more prone to the tuberculosis. That means it is important for these patients have a follow-up for TB. Next to that, on chest x-ray, you will see these patients have the eggshell calcification. They have eggshell calcification and snowstorm appearance. And snowstorm appearance. So these are all the characteristics of the silicosis. Is that clear? Number first one, most common type. Number second, the dust exposure is going to be a stone dust. Number third, they are more prone to the tuberculosis. Number four, eggshell calcification seen on the chest x-ray. Number fifth, there's going to be snowstorm appearance. Now if you see these two x-rays, you can see here this bilateral hilar calcification. Here it is going to be the eggshell calcification. It's going to be the eggshell calcification. And this one, the next chest x-ray, where we have this snowstorm appearance. But snowstorm appearance is seen with other conditions as well, right? What are the other conditions जहाँ snowstorm दिखता है? TB में भी दिखता है, COVID में भी दिखता है, right? Now next to that, if popcorn calcification on chest x-ray comes, then your answer is going to be the popcorn calcification on chest x-ray comes, then your answer is going to be pulmonary hematoma, which is the most common benign tumor of the lungs. That is going to be the most common benign tumor of the lungs. Clear? Now next to that is asbestosis. Now about the asbestosis, let's remember. So first of all, this asbestosis, it is the only pneumoconiosis associated with a malignancy. It is associated with the malignancy. And the industry it is seen with, it is shipbuilding or shipyard industry. Shipbuilding industry. On the peripheral blood smear, you will see we have these table tens or the racket shaped bodies, which are called as ferruginous bodies, which is also called as asbestos bodies, and they are made up of iron. That's why you can stain these with the Prussian blue stain. Very good. And most common malignancy associated is going to be bronchogenic adenocarcinoma or adenocarcinoma of lung. Adenocarcinoma of lung. And most specific, that is going to be mesothelioma. And mesothelioma में कौन सी body दिखेगी? That is going to be the samoma bodies. Mesothelioma will have samoma bodies. Okay. And what is going to be the marker for mesothelioma? Yes, very good. We have ground glass opacity on the chest x-ray for the asbestosis. Very good. And what is going to be the marker for this mesothelioma? If a clinical case will come and they will write rather other findings, pleural thickening, they will write calretenin positive. They will write calretenin positive. So you think of a asbestosis. You think of an asbestosis. So this is again the previous equation from the NEET PG. If a peripheral blood smear image is given and we have these table tense bat-like structures or the dumbbell shaped bodies, this is going to be the ferruginous bodies. This is going to be the ferruginous bodies, which are made up of iron. Clear to that? And below that we have these calcium concentric bodies, lamellated bodies. These are going to be a samoma bodies, and they are made up of calcium. So if equation comes, what is the stain used for these bodies? Your answer is going to be the either alizanin red or the von Casa stain or the von Casa stain. Both the stains are for the calcium. Both the stains are for the calcium. Clear? And these are the bodies which are also seen with the papillary thyroid cancer, meningioma, and serous cyst adenoma. Right? Chalo. Now next question. Sorry, next one is going to be a bisonosis. Now about the bisonosis, so the dust is going to be the cotton dust, okay, and it's usually seen with a textile industry. Textile industry. Okay. Next to that, we have a bag of sauces. Bag of sauces, remember, it is going to be a sugarcane dust, and they will give the history. There is a cardboard industry because the raw material used is bagasse. Okay. Now, next to that, we have anthracosis. Anthracosis is related to the exposure to the coal dust, and in case the patient is having anthracosis along with the rheumatoid arthritis, okay, that syndrome is called as Kaplan syndrome. क्या बोलेंगे उस syndrome को? That syndrome is called as Kaplan syndrome. Okay, and remember, in anthracosis, due to the inhalation of these carbon particles, we have which lung? We have anthracotic pigment, which turns the lung in a black color. And also, one more thing about the anthracosis, you will remember, there is progressive massive fibrosis. There is progressive massive fibrosis. That means even if you remove this patient from the exposure, the fibrosis will still continue. The fibrosis will still continue. Okay. And last one, it's going to be berylliosis. It is associated with air space industries. Air space industry. So that is all about the different types of pneumoconiosis. So remember, silicosis and asbestosis and anthracosis, they have been asking the questions repeatedly from the pneumoconiosis. The question has been asked repeatedly from the pneumoconiosis. Next to that, epidemiology is the study and analysis of the distribution patterns and the determinants of the health and disease. Now, which among the following correctly defines the generation time in epidemiology? Again, the previous question asked repeatedly. Now, sir, we have a different definitions. Now, first one, we have already discussed what is going to be the interval between marriage and the birth of the child. We have discussed just few minutes away. That is going to be which phase of the family cycle? Write down in the chat box. From the marriage and the birth of the child. Very good. So that is going to be the formation. That is going to be the formation. Very good. Now, next to that, so interval between the entry of organism till the maximum infectivity. Very good. That, or till the period of communicability, that defines the generation time. That defines the generation time. Next to that, so the interval between the primary and the secondary case. Very good. Excellent. Interval between the primary and the secondary case, that is called as serial interval. That is called as serial interval. Okay. Interval between the entry of infectious agent and the symptoms of disease, that defines the incubation period. That defines the incubation period. Okay, so this is all about the different definitions. So what is going to be the answer? It's interval between the entry of organism till the maximum infectivity of the disease. Till the maximum infectivity of the disease. Now, sir, interval between the entry of infectious agent till detectable antibody present. What is the answer? Till detectable antibody. That period is called as, write down in the chat box. Very good. That is going to be your window period. That is going to be the window period. That is going to be the window period. That is going to be the window period. Clear? Yes. Now, two more definitions that they can ask is going to be, quarantine and isolation. Quarantine, and number second is going to be the isolation. Number second one is going to be the isolation. Now, what exactly is quarantine? So quarantine means there is going to be the separation of suspected or healthy people till how long? Till maximum incubation period. Till maximum incubation period. Okay. And what defines an isolation? Isolation means there is separation of diseased person. There's a separation of diseased person till period of communicability or period of infectivity or period of infectivity. Is that clear? So that's all about the different definitions. What exactly is formation, generation time, incubation period, window period, serial interval, quarantine and isolation. Quarantine and isolation. Quarantine and isolation. Let's move with the next question. Clear to everybody? Yes. What is the recommended vaccination schedule for a post-exposure prophylaxis for rabies in a previously vaccinated individual? In a previously vaccinated individual. Now you have a patient with you and patient is coming after the dog bite, but the patient says, sir, I was already vaccinated. Now, if somebody is already vaccinated, what is going to be the post-exposure prophylaxis for them? Now, first of all, about the rabies, you remember. So what is the rabies main points? First of all, the case fatality rate of rabies is 100%. Okay. Next to that, the virus causing rabies, it's going to be a Lissa virus. Next to that, the intracytoplasmic inclusion bodies, which are confirmatory as well, they are going to be a Negri bodies. They are going to be a Negri bodies. And what is the motor protein involved in the rabies? That is going to be the dynein. Motor protein involved, that is going to be the dynein. Okay. Now let's understand, sir, what are the different ways or what are the different schedules for the rabies vaccination? Now we have three things: either pre-exposure or post-exposure not vaccinated, or the post-exposure vaccinated, or the post-exposure vaccinated. Very good. Less than 3 months, nothing to do. Very good. Now for this question, sir, he was previously vaccinated and everyone is right. Yes, so that is going to be wound cleaning with rabies vaccine on day 0 and day 3. On day 0 and day 3, that means 2 doses. Now let's understand. So pre-exposure prophylaxis, that means pre-exposure you are giving before the bite. Pre-exposure prophylaxis you are giving before bite. And before the bite, how many doses? So we are giving 3 doses, and these 3 doses to be given in a way: day 0, day 7, then the booster on 21 or 28, then the booster on 21 or 28. Then post-exposure prophylaxis. On post-exposure prophylaxis, if a patient is not vaccinated, we give with the 2 regimes: Essence regime, which is intramuscular, and we have a Thai Red Cross regime, which is intradermal. Intramuscular, you're giving 5 doses, that is 0, 3, 7, 14, and 28. 5 doses. And Thai Red Cross regime, you're giving intradermal, that is going to be the 4 doses: 0, 3, 7, and 28. So you're skipping it on the day 14. So that is going to be the 4 doses. That is going to be the 4 doses. Clear to everybody? Yes. Now next to that, sir, post-exposure prophylaxis. If a patient is already vaccinated, what to do? Bache? Now post-exposure, if less than 3 months, then no intervention. Nothing to be done. But if more than 3 months, you have to give 2 doses. That is day 0 and day 3. That is going to be day 0 and day 3. So that is all about the rabies vaccination schedule. Then also you give the rabies immunoglobulin as well, Equirap 40 international unit per kg. Is that clear? So that is all about the rabies vaccination schedule. Now next question, that is going to be from the test of significance. A cardiologist wants to study the effect of a drug, that is atorvastatin. He notes down the initial cholesterol levels of 50 patients and then administer the drug on them. After the month's treatment, he measures the cholesterol levels again. Now, which of the following is the most appropriate test of significance, or which of the following is the most appropriate to test the statistical significance of the change in the cholesterol levels? So whenever we solve such questions, the first very thing you have to see the type of data. First question, you have to see the type of data. Now data can be of two types. One can be a quantitative data, one will be a qualitative data. One is going to be a quantitative data, one is going to be the qualitative data. Now what exactly is a quantitative data? Sir, quantitative data means measurement is possible. Sir, it means measurement is possible. What is qualitative data? Sir, measurement is not possible. Measurement is not possible. Okay. Now, if the measurement is possible, we are using a which type of test? We are using a parametric test. Okay. So for quantitative data, we are using a parametric test. And for a qualitative data in which measurement is not possible, we are using a non-parametric test. We are using a non-parametric test. Clear? So whenever such questions are coming in front of you, the first very thing, bache, you will see that what type of data has been given. Now for a parametric test, the questions that they ask, we have three main tests. So we have a student paired test, student unpaired test, and we have a ANOVA test. Now listen. Now first, when you compare between the one group only, for example, you have a group of 5 people and 5 people have the cholesterol levels of 250, and I'm telling these 5 people that you take a hypolipidemic or a statin, which is an atorvastatin, for a 1 month. Now my dear students, after 1 month I'm going to check the cholesterol levels of the same 5 people. So before the intervention and after the intervention, I have a same group. Now that test that I've used for the same group, that is going to be a paired student t-test. That is going to be the paired student t-test. Clear? The next group, if you have two groups, 5 and 5, both of them have 250 cholesterol. One you are telling go with an atorvastatin, another group is going for lifestyle modification. Now after a 1 month, you are going to compare between two groups. You are going to compare the cholesterol level between two groups. One with the atorvastatin, one with the lifestyle modification. At the test that time you will use is going to be the unpaired student t-test. That is going to be the unpaired student t-test. Got it, guys? And if you have more than two groups, the test you use is going to be the ANOVA test. The test we use is going to be the ANOVA test. But bache, what is the first thing you see? First thing you see is a type of a data. First thing you have to see is the type of the data. Okay, now let's write it in the short manner. So the first thing, if we have a student t-test, now student t-test, we have paired student, and we have unpaired student t-test. Now paired student t-test, it is for a one group. It is done for the one group, and unpaired students, it is compared between two groups. And in case we have for more than two groups, it is going to be the ANOVA test. It is going to be the ANOVA test. Clear to everybody? Yes. Now here in this question, it was mentioned that the initial cholesterol levels of 50 patients and then administer the drug on them. After the month, he measured the cholesterol level again for the same group. So what is going to be the answer? Very good. It is going to be the paired student t-test. Paired student t-test. So one group. Two groups, unpaired student t. More than two, ANOVA test. So these are all three parametric tests. Now what is chi-square test? It is a non-parametric test. Now what if you have a data? Now, what if you have a data which is a qualitative data where measurement is not possible? For example, type of anemia. Can we know the type of anemia? Can we measure the anemia in the percentage? No. We can know the type of anemia, right? Or for example, the stage, cancer staging. Are you getting my point? Can we measure the cancer staging? No, sir. We can just give in a order form. Are you getting my point? We call it as ordinal data. Okay. And when you name something like type of anemia, we call it as a nominal data, right? So for that type, we have a non-parametric test. And in non-parametric test, the first test is a sign test. And sign test is used for a one group. Okay, sign test used for a one group. And we have also chi-square test. And this chi-square test, it is for two unpaired or more than two groups. We have other non-parametric tests as well, but this much is enough for an FMG thing. Is that clear? So sign test and chi-square test. Okay, parametric tests, they will always mention that mean and standard deviation was calculated. Okay, and here in non-parametric, there will be percentage and proportion. There will be percentage and proportion. So if a question says that which of the following test is used among these four for two or more than two proportions, which of the following tests will be used? Your answer is going to be a chi-square test. Your answer is going to be the chi-square test. Clear? Yes, that is going to be the chi-square test. Now let's move to the next question. A 32-year-old female, para 3, live 3, visits a gynecology OPD for the contraception. On examination, you notice down that there's a foul-smelling discharge. There is a foul-smelling vaginal discharge. Which of the following contraceptive method is relatively contraindicated in this case? So, which of the following contraception is going to be the contraindicated in this case? Very good. Your answer is going to be easy catch, intrauterine device. So IUDs, contraceptive devices, they are going to be contraindicated in case of a PID. In case of a PID. Is that clear? Clear to everybody? Now let's remember about the contraindication and side effects of ICD. Now, first of all, we have absolute contraindications. We have absolute contraindications. So what are the absolute contraindications? First of all, sir, if we have suspected pregnancy, that is going to be the absolute contraindication. Followed by that, if a patient is having undiagnosed bleeding per vaginal. Next to that, if a patient is having a current PID, or if a patient is having cervical cancer or polyp. That is all about the absolute contraindication. That is all about the absolute contraindications. Now, what are the relative contraindications? What are the relative contraindications we have? First of all, if you remember, the most common side effect of this intrauterine contraceptive device, that is going to be menorrhagia. So excessive heavy bleeding will be there. So if a patient is having anemia, can we give? No, sir. It will further decrease the HB. So anemia will be a relative contraindication. Or if a patient is having a fibroid, so fibroids can go bigger and it can cause penetration as well. Okay, or displacement as well. Next to that, if a patient is having history of PID, again a relative contraindication. If a patient is having history of ectopic pregnancy outside the uterus, also what is going to be the cause? Main cause is PID, but other cause can be use of ICD as well. Next to that, if a patient is having some Mullerian defect or the malformation of the uterus, like septate uterus, bicornate uterus, again that is going to be the relative contraindication. Or if a patient is having the history of multiple sex partners, because multiple sex partners will increase the chances of infection, and the most common cause for removing of ICD, it's going to be the infection. It is going to be the infection. So that is all about a relative contraindication. That is all about the relative contraindication and as well as the absolute contraindication, as well as the absolute contraindication. Clear to everybody? Yes. Just a second. Now write down in the chat box what can be the further side effects. Write down in the chat box what can be the side effects of the ICDs. First of all, sir, it can lead to the menorrhagia and polymenorrhea. It can lead to the menorrhagia and polymenorrhea. What does that mean, sir? More than 80 ml bleeding and polymenorrhea less than 21 days. Clear? So menorrhagia and polymenorrhea. At that time, again, a previous year question, what will be the management? So you have to remove the ICD? No, sir, we are going to give reassurance plus iron and folic acid. Plus iron and folic acid. Number one. What if there is pain as a side effect? So pain means infection. Will remove IUCD and start antibiotics. Will remove and start with antibiotics. Then what are the other side effects? It can lead to the ectopic pregnancy. So due to the infection, it can lead to the ectopic because infection or PID is going to be the most common cause for that. So it can lead to the perforation due to the displacement. Okay, it can lead to the anemia due to the heavy bleeding. So do remember that if a patient is having, the heavy bleeding post ICD, reassurance with iron folic acid. If a patient is having pain, remove the ICD and start antibiotics. Clear? Now, what if there is a pregnancy with ICD in situ? That means, what if there is a pregnancy with ICD there? First of all, it's a contraception failure. You can go for the medical termination of pregnancy, or you can go for the abortion up till 20 weeks only when there is a contraceptive failure. Followed by that, first, if a patient wants to continue the pregnancy, leave it there only. If a patient does not want, remove the ICD. Okay, remove the ICD. Clear? And then we can go for the MTP. Clear? And if the ICD is inside the uterus, remove with the hysteroscopy. If outside the uterus, you remove with the laparoscopy. Now, let's move to the next part. Now, about the OCPs, remember that OCP increase the cancer, hepatic adenoma, breast cancer, and cervical cancer, and OCP decrease the cancer. I will write it here only. Okay. About the OCPs increase the cancer, which one? Hepatic cancer, breast cancer, and cervical cancer. So OCPs decrease the cancer, endometrial cancer, uterine cancer, and ovarian cancer. So do remember this as well. Clear? Now let's move to the next question. A 40-year-old chronic alcoholic presents with a shortness of breath, pedal edema, and tachycardia. On examination, he has elevated jugular venous pressure, JVP is elevated, a hyperdynamic precordium and bilateral basal crepitations are seen. On echo, it reveals that we have a dilated cardiomyopathy with a high cardiac output. Which vitamin deficiency is there? Alcoholic is the hint, dilated cardiomyopathy is the two hint. Yes. What is going to be the answer? Very good. It is going to be vitamin B1. It is going to be vitamin B1 deficiency. Very good. Now let's understand in a fast manner. Now vitamin B1, sir, it is going to be thiamine. Thiamine deficiency is usually seen with the polished rice eaters. Okay. Followed by that, it causes beriberi. It causes beriberi, dry beriberi, and wet beriberi. Then followed by that, in alcoholics, this vitamin B1 deficiency is there. In alcoholics, they will lead to the alcoholic induced neurocognitive disorders. We have two main ones, that is going to be Wernicke's encephalopathy. In Wernicke's encephalopathy, you will remember three main features: having global confusion, ophthalmoplegia, and ataxia. You remember with the Goa. Followed by that, it can lead to the Korsakoff psychosis. उसमें क्या याद रखोगे? We have confabulation and retrograde amnesia. That is all about the vitamin B1 deficiency. Next to that, you remember that the dilated cardiomyopathy is caused by the alcohol. Hypertrophic obstructive cardiomyopathy, it is seen with the young people, athletes. Restrictive cardiomyopathy, it is the only myopathy which is associated with the amyloidosis. These are the three main questions from the cardiomyopathies. Dilated को alcohol लगाना, young athletes HOCM, है ना, beta myosin chain defect, and then we have this restrictive associated with amyloidosis. Clear? And then if somebody has an heartbreak, we have Takotsubo cardiomyopathy, right? Now, sir, the question was asked in the NEET PG that once a patient is having this Wernicke's encephalopathy and this Korsakoff psychosis, what are you giving first? So we are giving thiamine first, followed by that we will give glucose. Never give glucose first, because for the oxidation of the glucose, more vitamin B1 will be depleted, and due to which what will happen? Some more global confusion, more ophthalmoplegia, and more ataxia will happen. So treatment, injection vitamin B1 or injection thiamine followed by the glucose. Never give glucose first. That is all about the vitamin B1. Clear to everybody? Vitamin B6, that is going to be pyridoxine, and pyridoxine deficiency will lead to the peripheral neuropathy. It will lead to the peripheral neuropathy. And vitamin B6 deficiency is also a side effect of a drug that is isoniazid. That is why whenever we give isoniazid, we give along with that a counter drug to decrease the side effect. That is going to be the pyridoxine. Clear? So that is about vitamin B6. Vitamin B12, it is going to be cyanocobalamin. Okay, it will lead to the megaloblastic anemia. That means MCV will be more than 100. Followed by that, it is seen with the strict vegetarians. Sir, both MMA and homocysteine levels will be increased on the lab. Both levels will be increased in the lab. And next to that, remember that it also leads to the subacute degeneration of myelin. Is that clear? So that is why you also remember that. If a neurocognitive features, or if the neurological deficit features are associated, they will be associated with the vitamin B12, not with the B9. Even though B9 and B12 both causes megaloblastic anemia. So how do you differentiate in terms of the clinical features? Neurological deficit features are with B12, while as B9 does not have these features. And MMA level and homocysteine level both will be raised in the B12, while as MMA levels will be normal in case of a B9. Is that clear? That is all about the B12. Okay. Then we have a vitamin B2. B2 is going to be the riboflavin, and riboflavin will cause a deficiency that tried called as ariboflavinosis. So how do you remember? C for ciliasis, A for angular stomatitis, and G for glossitis. Okay, I will write here ciliasis, angular stomatitis, and glossitis, which is also called as geographic tongue. And CAG is a trinucleotide repeat for, write down in the chat box. CAG is going to be the trinucleotide repeat for Huntington's chorea, chromosome number 4, and drug of choice is gonna be tetrabenazine or valbenazine. Clear to everybody? Then vitamin B3, that's going to be niacin, have a property of increasing the HDL and decrease the LDL. 60s, that is going to be diarrhea, dermatitis, delirium, depression, and we have death, right? And then we have B5 pantothenic acid. It leads to the Soul syndrome or the burning feet syndrome. B6, I've already discussed. B7, biotin, hair loss, alopecia, right? And also seen with the raw egg consumers because of the presence of evidin, which decrease the B7 absorption. Next to that, we have B12, that's what we have already discussed. B9, folic acid deficiency will lead to the megaloblastic anemia, and in pregnancy, the deficiency will lead to the neural tube defects. And most common is going to be spina bifida. That is why the folic acid deficient, that's why in the pregnancy, as per the Anemia Mukt Bharat, how much folic acid will be given in the pregnancy? 500 micrograms. But if a patient is having a history of this neural tube defect, then you give 4000 micrograms per day. And it will also lead to the megaloblastic anemia. That is all about the vitamins. That is all about the vitamins. Can we move to the next part? Yes. A 25-year-old man is diagnosed with a paucibacillary leprosy. It is diagnosed with a paucibacillary leprosy. He's planned to start a multi-drug therapy. His weight is 60 kg and he has a normal renal and liver function test. Which of the following represents the correct daily dose of the tablet? Now we have to answer the correct dose of dapsone. First of all, which type of leprosy? You already know. The leprosy is caused by Mycobacterium leprae with an incubation period of 20 years. Now we have two types of leprosy. One is going to be paucibacillary. One is going to be a multibacillary leprosy. One is going to be the paucibacillary. Next one is going to be the multibacillary. Now paucibacillary leprosy, the lesions are going to be less than 5 lesions. Or 1 to 5 lesions. Here will be more than 5 lesions. Here we have more than 5 lesions. Paucibacillary, sir, the treatment is for the 6 months. The treatment is for the 6 months. Here the treatment will run for 12 months. In paucibacillary, no nerve involvement. Here, one or more than one nerve is going to be involved. Drugs will be same. Dapsone, clofazimine, rifampicin here. Here drugs will be same, dapsone, clofazimine and the rifampicin. Is that clear? That is all about a paucibacillary and multibacillary. Now what are the characteristics of these patches? These are the hypopigmented patches, these lesions, or hypoanesthetic patches. It will be mentioned in the question that these are what patches? They lost the sensation. So they are hypoanesthetic or hypopigmented patch. This will be the classical hint written. This will be the classical hint written. Is that clear? Now, what is the nerve involved in the leprosy? So the nerve involved is going to be the ulnar nerve. Ulnar nerve. If which cranial nerve is involved? From the cranial nerve, it is going to be the facial nerve. It is going to be the facial nerve. Now, about these 3 drugs, that is going to be dapsone, clofazimine and rifampicin. What is the dosage of the dapsone? It is going to be option B, that is going to be 100 mg. That is going to be 100 mg. Again, the previous equation of the NEET PG. Now, next, understand first. So, multi-drug therapy reaching for the leprosy. Paucibacillary in adults, we give the treatment for 6 months. Dapsone, you have to give 100 mg daily. Clofazimine, 300 mg once a month, and then 50 mg daily. And rifampicin, you have to give 600 mg monthly. The only difference between paucibacillary treatment and the multibacillary, it is going to be the duration. Here the duration is 6 months. Over there, duration is the 12 months. Okay. For the children's 9 to 14 years of age, dapsone will be given half, that is 50 mg daily. And clofazimine will be given half, 150 mg once a month. And then 50 mg, you have to give alternate day. It is an INS set recall question 2019. So they have asked clofazimine, which of the following statement is correct about the treatment of the leprosy. So this was the option B, which was correct over there, that 150 mg monthly in children's with 50 mg alternate day for the clofazimine. And rifampicin, you have to give 450 mg once a month. Is that clear? That is all about the treatment for a leprosy, pauci and multi. Remember that also this dapsone is again a drug of choice for, yes, dermatitis herpetiformis. Also dermatitis herpetiformis associated with the celiac disease. And next to that, rifampicin side effect, you already remember orange colored secretions or the red secretions. Clear? Now about the lepra reaction, remember the rule of 5. We have type 1 lepra reaction associated with type 4 hypersensitivity and type 2 lepra reaction associated type 3 hypersensitivity. associated with type 3 hypersensitivity. Is that clear? So that is going to be the rule of 5. Now what is going to be the drug of choice for the lepra reaction type 2? That is going to be, drug of choice is going to be steroids. Okay, yes, we do use a thalidomide as well, but drug of choice here is going to be the steroids. Then Sapna and Meena from the image based question we have already learned in the, for the mascot for the leprosy we have Sapna and Meena, that we have already discussed in case of a main notes. Clear? So that is all about the leprosy and it's going to be the important. Now next to that, next question, everything is clear? Everyone out there online? In a hostel of 80 students, one boy developed varicella. 80 students were total, one developed varicella, chickenpox. 5 students were immune, so vaccinated, 5 people were there. 20 new cases occurred within the incubation period. 20 new occurred within one incubation period. Calculate the secondary attack rate. Calculate the secondary attack rate. Now, my dear students, what is a primary case? It's the first case of the disease. What is a secondary case? It's the cases that were developed from the contact of the primary case. Now, out of these 5 were immune. Now, primary cases are how many? The primary was 1. So from this one student, how many developed chickenpox or varicella in one incubation period? 20 new cases. So secondary cases are 20. So immunized people are 5. Immunized people are 5. Okay. So let's see how many people are suspected. Let's understand first. Now, how many are suspected? So first of all, we have the formula for the secondary attack rate. That is number of secondary cases in single incubation period divided by total number of suspected multiplied by 100. So among total 80 people, so among 80 people, I subtract the 5. Why? Because they were immune. So suspect mein aata nahi. And the one primary case. So among 80 people, 74 were suspected. 74 were suspected. So put on the formula. Number of secondary cases. Secondary is 20. Suspected is 74. So formula goes 20 by 74 multiplied by 100. That is 2000 by 74. That goes around 27%. So what is a secondary attack rate? What is the secondary attack rate? So secondary attack rate is 27%. Secondary attack rate, it's going to be 27%. Clear to everybody? That is going to be 27%. So first find out the primary cases, उसके बाद secondary निकालो, उसके बाद immunize how many are immune, and then you have to subtract those people. Do not subtract the secondary cases in suspected, okay, because they were about to develop the disease. So you only subtract the primary case with the immunized people, then rest remaining population is going to be the suspected population. Clear? And what is a primary case? First case of the disease. Secondary case developed from the contact of primary case. What is index case? Index case means first reported case. Index case means first reported case. It means first reported case. Clear? Now let's move to the next question. A 30-year-old man presents with a single painless genital ulcer and non-tender inguinal lymph nodes. He has no history of penicillin injury. Under the syndromic management, which kit should be prescribed? Under the syndromic management, which kit should be prescribed? Now, if you remember that under the National AIDS Control Program, which was given by the National AIDS Control Organization, they mentioned one postulate over there that there should be a free reproductive health services. Okay, and among those services, we have the syndromic management, which is given by a Suraksha clinic. Okay, now let's understand what exactly, as per the Suraksha clinic, they provide the syndromic approach. Which kit you will prescribe for a patient for a painless genital ulcers, which is with non-tender inguinal lymph nodes with no history of penicillin? Write down in the chat box, everybody. Write down in the chat box. Yes, now audio is fine. Very good. It's going to be kit 3 white. It's going to be kit 3 white. Okay. Now let's understand about the Suraksha Clinic. Now, sir, the Suraksha Clinic. Now, the Suraksha Clinic, they will provide the reproductive tract infection services or sexually transmitted infection services. Clear? And these services will be based up on the symptoms. They will be based up on symptoms. That will be based up on symptoms, not on the diagnosis. They will be based upon symptoms, not on the diagnosis. This is what you call as syndromic management. इसी को क्या बोलते हैं बच्चे? Syndromic management. Now, when I talk about this syndromic management, what does that mean based upon symptoms? If a patient is coming to you with a vaginal discharge, now this vaginal discharge can be anything. It can be a curdy vaginal discharge, goes with the candidiasis. It can be a creamy vaginal discharge, goes with the bacterial vaginosis, or it can be a greenish discharge, goes with the trichomoniasis. But here, as per the Suraksha Clinic, if a patient is complaining of a vaginal discharge, you directly prescribe a kit. You do not exactly diagnose what kind of a discharge is this. So we give 8 color kits as per the symptoms, based upon the symptoms. Now, any patient complains of urethral discharge, any patient complains of urethral discharge, or any patient complains of a cervicitis or painful scrotal swelling we prescribe a kit 1, which is going to be kit 1 gray, which is kit 1 gray. Thank you, Dr. Kuldeep. I'm glad my sessions helped. Okay, keep going on, prepare for the PG and get the PG done as well. There's a long way to go, and all those students who are going to appear on 28th of June, you guys are going to pass for sure. And again, after this, you are going to get on the track for the NEET PG as well, because there is a long way to go, right? Chalo. Now, next to that, kit 2 green color. Now, about the kit 2 green, remember, sir, kit 2 green color, it is for a vaginal discharge. Kit 2 green, that is for the vaginal discharge. Okay. Now, next to that, white, blue, and red. White, blue, and red, they are all for the genital ulcers. But what is the difference? So we have white color for the non-herpetic genital ulcers. And these are responding to penicillin. Responding to penicillin. Next to that, blue color. This is again a non-herpetic genital ulcers. But blue color kit will be for those people who are allergic to penicillin or resistant to penicillin. Then next to that, red color, that is for genital ulcers, but they are herpetic genital ulcers. They are herpetic genital ulcers. They are herpetic genital ulcers. Clear? Now, next to that, yellow color kit. Yellow color kit, any patient coming with the complaints of an abdominal pain, most likely pelvic inflammatory disease, you go with a kit yellow. And kit yellow contains how many medicines? 3 medicines. That is going to be doxycycline, cefixime, and metronidazole. While as red contains, that will contain only the acyclovir. Then black color. So black color is for the inguinal bubo. And inguinal bubo mein, what you will remember? Inflamed lymph nodes. Inflamed lymph nodes. And kit 8, it's a new kit introduced last year, and kit 8 will be given to the patient who will complain of an anorectal discharge. Before it was kit 1 for the anorectal discharge. So what is your answer for the patient complaining of urethritis? Gray color. Vaginal discharge, green color. Gray mein cefixime and azithromycin is there. Green mein we have fluconazole and secnidazole. Then white, blue, red, depending upon herpetic genital ulcers responding to penicillin, white. Non-herpetic genital ulcers responding to penicillin, white. Non-herpetic genital ulcers resistant to penicillin, blue. Herpetic genital ulcers, red, acyclovir. Then yellow for the abdominal pain, PID, we give the 3 drugs, DCM. Black color for the inflamed lymph nodes, and brown for the anorectal discharge. So in this question, simply it was the white color. It was the white color. Next question, guys. Government of India started the Anemia Mukt Bharat program. What is the dose for the iron folic acid for the adolescent girl? For the adolescent girl, that means age 10 to 19. So age group of 10 to 19, what will be your dosage for the iron and the folic acid? What will be your dosage for the iron and the folic acid? Very good, sir. This was the initiative launched by the government in order to decrease the prevalence of the iron. That means decrease the new cases as well as old cases. You need to treat them every year by 3%, by 3%, by 3%. Now, sir, as per this Anemia Mukt Bharat, we have a strategy called as 6 into 6 into 6 strategy, where 6 are the beneficiaries, 6 are the interventions, and 6 institutional mechanism. Okay, now in this 6 into 6 into 6 strategy, 6 beneficiaries, that the question they have asked, that sir, very good, what will be the dosage? Yes, it's going to be the option C. 60 mg of iron will be giving 500 micrograms of folic acid weekly. So it is, what is the frequency of these 2 drugs? That is going to be weekly. Now 6 months to 5 years, what will be the iron dosage? So 20 mg of iron with 100 micrograms of folic acid, but the frequency is going to be twice a week. Frequency is going to be twice a week. Next to that, 6 years to 10 years, iron 45 mg will be given with a folic acid 400 micrograms, and frequency is going to be weekly. Now from 10 years till the lactation, the dosage is going to be same. 60 mg of iron with 500 micrograms of folic acid, but the only difference is going to be the frequency. So here it is weekly. 60 mg of iron, 500 micrograms of folic acid, again weekly. Here 60 mg of iron, 500 micrograms of folic acid daily. And also in lactation, 60 mg of iron, 500 micrograms of folic acid, again that has to be given daily. Is that clear? But if in case it is mentioned in the question, patient has history of neural tube defect, then your answer is going to be 4000 micrograms per day folic acid. Is that clear? Yes. So that is all about the iron and folic acid. Now remember also that which worm causes iron deficiency anemia? Hookworm also causes, sir, iron deficiency anemia. That is why in pregnancy we have to go with the albendazole, which is also an intervention for the Anemia Mukt Bharat, that we have to deworm the patients as well with the albendazole. And which worm causes the megaloblastic anemia? That is fish tapeworm or Diphyllobothrum latum, that causes megaloblastic anemia. Is that clear? So that is all about the iron and the folic acid and Anemia Mukt Bharat. Clear? Now next to that is the question that has been repeated in your exams from the food adulteration diseases. So a patient from different age groups from a village in West Bengal came to the clinic with an illness. On examination, it is noted that all of them were having the edema. On history taking, it was found that they were consuming the mustard seeds. So edema is the hint, mustard seed is the hint, which was bought from the same local shop. What is the most probable diagnosis? What is going to be your most probable diagnosis. Now bache, first of all, we have different food adulteration disease. Now if a patient is having this edema and the food stuff is going to be mustard, it is classical diagnosis of, very good, it is a diagnosis of epidemic dropsy. It is a diagnosis of epidemic dropsy. And what are the clinical features of epidemic dropsy? So these patients will have bilateral edema or the swelling of the legs. Followed by that, these patients can have ocular manifestations like glaucoma. They can have diarrhea as well. They'll have cardiac failure as well, and dyspnea as well. These are all the features of the epidemic dropsy. And for the epidemic dropsy, what is the toxin responsible? It is going to be the sanguine. It is going to be the sanguine. Clear? Now let's understand the different food adulteration disease and different types of the toxins associated. Now if I talk about the first disease, we have letharism. Now in letharism, the toxin is going to be BOA. Toxin is going to be BOA. What is the full form of BOA? It's beta oxalylaminoalanine. It's beta oxalylaminoalanine. The agent for this is going to be K-saridal. And the food stuff is yellow pulse. And the food stuff is yellow pulse. Now bache, this features of this letharism will be, what will these patients have who have this letharism toxin BOA? So they have osteoparalysis. They have osteoparalysis and neuroparalysis. They will have a features of abnormal gait. So image will be given that there is a gait defect. Okay, there is a gait defect. Okay, now there will be an image having an osteoparalysis with the history of this yellow pulse. Think of a BOA. Think of a BOA. Is that clear? Yes. And if the question mentions also upper motor neuron signs related to that, think of a neuroparalysis. So osteoparalysis, neuroparalysis, diagnosis is letharism, toxin is BOA. Now next to that, the second one that we have already discussed, bache, that is going to be an epidemic dropsy. That is going to be the epidemic dropsy. Okay, in epidemic dropsy, what is the toxin? Just now we have sanguine. Okay, and agent is argemone seed. Argemone seed, and the food stuff is mustard. And the food stuff is mustard. So clinical features for that we have already written over here, that is diarrhea, dyspnea, glaucoma, edema, and cardiac failure. Next to that, we have the third one, which is endemic ascites. Endemic ascites. In endemic ascites, the toxin is going to be pyrrolizidine. Pyrrolizidine. The food stuff is going to be, agent is going to be Corotorla seeds. And food stuff is going to be millet. Food stuff is going to be millet. Now endemic ascites, pyrrolizidine, it itself says in the name only that the patient will have a features of ascites and jaundice. So if it mentions that there is an abdominal distension with increased liver enzymes, think of a endemic ascites. Think of a endemic ascites. Now next to that, we have the very repeated question asked, aflatoxicosis. Now aflatoxicosis, the toxin is going to be aflatoxin. And this aflatoxin with the features, which one among these causes hepatocellular carcinoma with increased alpha fetoprotein levels? You think of an aflatoxicosis. Your answer is going to be aflatoxin. And what is the food stuff? They will mention the patient was working with the groundnut factory. Put the groundnut. And agent is going to be Aspergillus flavus. Agent is going to be Aspergillus flavus. Okay. And next to that, last one, we have a ergotism. Last one we have is ergotism. And the toxin with ergotism, bache, it is going to be ergot alkaloid. It is going to be ergot alkaloid. And what will be the clinical features? It will lead to the vasospasm gangrene. The food stuff is going to be flowering plants. Food stuff is going to be the flowering plants, and agent is going to be Claviceps fusiform. Is that clear? So that is all about the food adulteration disease. So remember, lathyrism with the bova, endemic ascites with the sanguine, endemic ascites with the pyrrolizidine, epidemic dropsy with the sanguine. Let's aflatoxicosis for the aflatoxin and ergot alkaloid for the ergotism. Now, how exactly we can remove these toxins? So we have to go for the steeping method or the parboiling method. We can put them under water with a 20% saline so that the removal of toxins can be seen. Now, next to that, so we can aware the people about the consequences of consuming such food. So we can aware them, educate them, or we can start with the vitamin C prophylaxis as well, or at the most we can ban the crop. So this is for the preventive measures for these food adulteration diseases. Clear to everybody? So if a patient comes with the complaints of a vasospasm gangrene, think of a ergotism. Toxin is ergot alkaloid. If there is a history of hepatocellular carcinoma, groundnut given, think of a aflatoxicosis. If aside is jaundice, increased liver enzyme with the abdominal distension, think of an endemic ascites with the pyrrolizidine. If there is a neuroparalysis, osteoparalysis, think of a kesari dal and the lathyrism. And if the cardiac failure, dyspnea, diarrhea, and glaucoma, think of an epidemic dropsy, that is going to be sanguine. Is that clear? So either the symptoms will be asked and you have to answer the toxin or the diagnosis. Now the next one is from the screening. Now they can ask the patient to calculate the sensitivity and a specificity. Okay, now if we talk about the screening first, so what is screening? So it is which level of prevention? It is a secondary level of prevention. It is going to be the secondary level of prevention. Followed by that, secondary level means early detection and treatment. Early detection and treatment. Now, my dear students, whenever we go for a screening test, the test results can be either it can be a positive test, either it can be a negative test. Either the test is positive or the test is negative. When the test is positive, there can be two scenarios. When the test is positive, there can be two scenarios. So what can be the two scenarios when the test is positive? The scenario number one, after the test is positive and the disease is present, I call it as a true positive. I call this as a true positive test. Okay. Test is positive and disease is absent. That means the positive that came, it was not true, it was false. That means it is a false positive test. It is going to be the false positive test. So simple words. So test is positive and the disease is present, it is a true positive. Test is positive and the disease is absent, it is going to be the false positive. It is going to be the false positive. Now next one, if a test result is negative and followed by that negative, if the disease is absent, that means negative, that means it is going to be the true negative. It is going to be the true negative. And once the test is negative and disease is present, that means the negative that was there, it is not true, it is a false negative. It is a false negative. Now this thing you have to understand, because when a question will come, they will give a data, and from the data you need to extract based upon your understanding whether it is a true positive, it is a false positive, it's a true negative, it's a false negative. Because when you have these four values, then only you can calculate the sensitivity, specificity, positive predictive value, negative predictive value. Correct? Now, if the test is positive and the disease is present, it was a true positive. Test is positive, disease is absent, it is a false positive. Test is negative, disease is absent, it's a true negative. Test is negative and the disease is present, it's going to be a false negative. Now, what exactly is sensitivity and specificity? Now, if we define the sensitivity, it simply means the ability of a test the ability of a test to correctly identify those who have the disease. So what is sensitivity? Ability of a test to correctly identify those who have the disease. Can I say it's a true positive people? Yes, who have the disease. What is specificity? So the ability of a test to correctly identify the individuals who do not have the disease, who do not have the disease. So disease किस किस में नहीं था? एक तो ट्रू नेगेटिव में नहीं था और फॉल्स पॉजिटिव में नहीं था. Disease was absent. Disease किस किस में था? It was true positive and false negative. So true positive had a disease and the false negative had a disease. And which among these do not have the disease? False positive के पास disease नहीं है and true negative के पास disease नहीं है. That's why in the formula will include in the first formula that who actually have the disease, that is going to be true positive and false negative. So what is the formula for sensitivity? It is going to be true positive by true positive plus false negative. What was true positive? Test positive, disease present. What was false negative? Test negative but disease present. And what do you mean by the sensitivity? The ability of the test to correctly identify those who have the disease, who have the disease. Now let's calculate one question on the sensitivity. A new test was used to detect a disease in 200 people. Out of these, 80 people actually had the disease, which was confirmed by the gold standard test. So test correctly identifies 72 as a positive and 8 people who actually had the disease, they were missed. So first of all, क्या करोगे आप लोग? So we'll calculate true positive people. True positive कितने? That is going to be 72. The test correctly identify those 72. And how many were missed? Then test, therefore false negative कितने रहे? False negative are 8 people. False negative are 8 people. False negative are 8 people. Now what is the formula for the sensitivity? So formula says true positive by true positive plus false negative multiplied by 100, which is equal to true positive 72 divided by 72 plus 8 multiplied by 100. That is 7200 by 88 goes 8 ones are 8 nines are, that is 90%. What is going to be the answer? The sensitivity of the test, that means the test correctly identify those who have the disease. 90% of people were correctly identified. Is that clear? That's how you calculate the sensitivity. That's how you can calculate the sensitivity of the test. Is that clear? Write me in the chat box. Yes, clear to everybody? Now next one, if you have to calculate the specificity of the test. Now what was the specificity? It's the ability of the test to correctly identify those who do not have disease. So what is the formula? True negative divided by true negative plus false positive. So you have a question given, 400 people were there without a disease. A diagnostic test correctly identified 350 people disease free and 50 were falsely identified and having the disease. So what is the specificity of the test? Now how do you calculate the specificity of the test? So we have true negatives divided by true negatives plus false positives plus false positive, right? Now bachche, tell me how many are the true negative first. So true negative we have 350 because correctly disease free, true negative. And how many were falsely identified? 50. So false positive we have, so 50 people. Okay, so put on the formula, that is going to be 350 divided by 350 plus 50 multiplied by 100. So that is 3 divided by 400. Okay, now 0 and 0 goes, 350 divided by 4, that is approximately 87.5%. So what is going to be your answer? 87.5%. Is that clear? Is that clear? So first of all, know exactly what are the true negatives, then know what are the true positive, and then only you proceed. Then only you proceed with the question. Clear? So sensitivity and specificity is clear? Yes. Chalo. Next, now what is a positive predictive value? Sir, the probability that a person actually has a disease when the test result is positive. So probability that usko disease hoga, that will be true positive by true positive plus false positive. Okay. And what is negative predictive value? The person truly does not have the disease. Okay. It is just a probability. True negative divided by true negative plus false negative. So that's all about the diagnostic test evaluations: sensitivity, specificity, and then post predictive value, positive predictive value, and negative predictive value, Now we have a PSM demography updates. Okay, first of all, sir, if we talk about crude birth rate, the new crude birth rate, it is 18.3 per 1000 mid-year population. Okay, then we have a crude death rate. Crude death rate is 6.4 per 1000 mid-year population. Okay, then we have infant mortality rate. We have 24 per 1000 live births. These are all the updates. Next to that, maternal mortality ratio, we have 87 per 1 lakh live births. And goal, you already know, goal is less than 70 by year 2030. That is maternal mortality ratio. And what is the difference between maternal mortality ratio and rate? So rate is also per 1 lakh, but rate mein denominator is women of reproductive age, while as ratio mein denominator is going to be the live births. Okay, direct cause hemorrhage, indirect cause anemia. Is that clear? That is all about the demography updates. Next to that, we have this Census India. Vikas, it's a male mascot, male enumerator, Census India 2027. It's the first digital census. It is going to be the first digital census. Okay, Vikas and Pragati. Vikas is a male enumerator and Pragati is a female enumerator. Is that clear? So mascots for the census, Vikas and Pragati, it might can be a image based question. Clear? Now the last one, let's understand the all disease and their agents and vectors, and we'll understand what exactly can be the questions asked from these diseases as well. So I will add on the extra points as well. Now first one, we have the brucellosis. Now about the brucellosis, you remember it is caused by B. melitensis. It is caused by B. melitensis, and the vector for the brucellosis, it is going to be unpasteurized milk. So whenever a history or a contact of the domestic animals is given, along with that, what is the classical type of fever seen? So classical type of fever with brucellosis is a swinging fever. Okay, and swinging fever is seen with a history of the contact with the domestic animals. Along with that, think of a what? Brucellosis. And brucellosis, may remember, we have two tests: Rose Bengal test and a milk ring test that we do. And the drug of choice for brucellosis is going to be doxycycline. It's going to be doxycycline. KFD में agent is going to be the group B arbovirus. Agent is going to be group B arbovirus, and vector is soft tick, hard tick. Vector is hard tick. Soft tick outside the India, but in India we have hard tick. Hard tick. Next to that, yellow fever. Again, for the yellow fever, virus is going to be same, group B arbovirus. Okay, for yellow fever, group B arbovirus, and vector is going to be Aedes mosquito. Vector is going to be Aedes mosquito. Okay, and about the yellow fever, vaccine is 17 strain D. Strain is 17D. And about the yellow fever, the vaccine that is valid after the 10 days of the administration and till the lifelong. Okay, certificate is only valid after 10 days. Leptospirosis, sir, L. interrogans, and the vector is going to be infected rat urine. And this leptospirosis is seen also with the post disaster. This leptospirosis, the features of conjunctivitis, remember please, conjunctivitis hoga yahan pe, with the renal failure, jaundice and hematuria as well. Followed by that, the leptospirosis mein drug of choice, which investigation, we check the leptospirin in blood and urine, and drug of choice for the mild cases is doxycycline, and the severe cases it's going to be a penicillin. Okay. Now next to that, echinococcus, the agent is echinococcus granulosus. The agent is echinococcus granulosus, and then vector is dog. Okay, it usually causes the hydrated cyst of the liver. It usually causes the hydrated cyst of the liver, and hydrated cyst of the liver, that is going to be the rounded lobe of the liver. Okay, right lobe of the liver. Now, first to that, about the hydrated cyst, what is going to be the treatment? Treatment is going to be the pair therapy. P for puncture, A for aspiration, and I for initiating scolodical agents, and R for re-aspiration. Is that clear? So that is all about the hydrated cyst, and we have this water lily sign as well. And what are these scolodical agents? So these are the agents which will shrink the size of the cyst, like albendazole. Okay. Now teniasis. You will remember we have Tinea solium and Tinea saginata. Tinea saginata, and vector is going to be pork or beef. And then you have this neurocysticercosis with a starry sky appearance. Drug of choice is going to be albendazole with steroids. And for the teniasis, they will cause intestinal infection. The drug of choice is going to be a niclosamide or praziquantel, and the praziquantel. Now plague is caused by Yersinia pestis, and then the vector is going to be rat flea. We have a most common type called as a bubonic plague, but the most severe is going to be pneumonic plague. And for the plague, remember one thing: for the prophylaxis we use the tetracycline, but for the drugs we use injection streptomycin. Next to that, we have a malaria. Remember, agent is going to be plasmodium. Then we have different: plasmodium ovale, plasmodium falciparum, plasmodium vivax, or plasmodium novelaceae as well, or malaria as well. Remember the question that will come, that first of all we have a investigation of choice as a peripheral blood smear. We take thick smear and a thin smear. Thick will confirm the disease, thin will tell me about the species. And we go for LDH as a rapid test, which will detect both falciparum and vivax. But we go for histidine rich protein test as well as a rapid test, which will only detect the plasmodium falciparum. Clear? Now, main question from the malaria that will come from the treatment bache: ACTL in the northeastern and ACT-SP in the other states. For the prophylaxis of malaria, remember we give doxycycline and mefloquine. Doxy in the short term, mefloquine in the long term. Short term, less than 6 weeks travel karna hoga, the doxy answer. More than 6 weeks, you mark with the mefloquine. About the malaria in the pregnancy, remember, if plasmodium vivax is there or plasmodium vivax anywhere in the country, one drug is going to be a drug of choice, that is going to be chloroquine. That is going to be the chloroquine as a drug of choice. But if it mentions northeastern, that is going to be ACT-L, and other states ACT-SP. Primaquine is contraindicated in the pregnancy. But if a question comes in the first trimester, a lady is pregnant and plasmodium falciparum is the agent, then your answer with first trimester is going to be quinine or quinine. And second trimester, northeastern state ACT-L, other state ACT-SP, and doxy and meflo for the prophylaxis. Is that clear? Now next to that, what will be the vector? It will be Anopheles female. It will be Anopheles female for the malaria. Then rabies, the agent is going to be a Lissa virus, and the vector is going to be the rabid animal. What is a rabid animal? The animal which contains rabies virus. Pre-exposure prophylaxis, 3 doses, 0, 7, 21 or 28. Post-exposure prophylaxis, vaccinated, 0, 3, more than 3 months, less than 3 months, no intervention. Post-exposure prophylaxis, not vaccinated, intramuscular, 5 doses, 0, 3, 7, 14, 28. Intradermal, 4 doses, 0, 3, 7 and 28. 14 you had to skip. Is that clear? And Visa virus and the motor protein involved is going to be a diamond. Okay? Then case CFR is rabies 100%. Negri bodies confirmatory. Chalo, dengue is caused by group B arbovirus also. So for the group B arbovirus, so far you remember a yellow fever, you remember a Japanese encephalitis, you remember the KFD, and as well as dengue, which is also called as bone break fever. The patient is going to have an undifferentiated fever in dengue. The first investigation is going to be NS1 antigen, and the most specific is going to be ELISA IgM. Now remember the complications: dengue hemorrhagic fever, then eventually dengue hemorrhagic shock. Okay. And when exactly you will go for the platelet transfusion? When the platelets are less than 10,000. But if there is a sign of bleeding present, then you just have, there is no limit. Then just give at 30, 40, 50, 70,000 you have to go for the blood transfusion if there is active bleeding. Do remember that aspirin and diclofenac is contraindicated because they can increase the chances of the bleeding. Okay, so group B, arbovirus for the dengue. And what is the vector? That is going to be Aedes mosquito. That is going to be Aedes mosquito. Then we have epidemic typhus. The agent is going to be R. typhi. The agent for epidemic typhus is going to be R. That is for endemic typhus. Epidemic typhus, it's going to be Rickettsia prowazaki. It is going to be Rickettsia prowazaki, and the vector is going to be louse. Vector is going to be louse. Okay, then we have endemic typhus. We have R. typhi, and the vector for this is going to be flea. We have scrub typhus. It's going to be Rickettsia sutsugumoshi. And remember, when a question for the scrub typhus sutsugumoshi will come, the classical case will mention that there is a black eschar formation as well. So this black eschar is going to be the hint for that. For the agent is sutsugumoshi for the scrub typhus, and the vector is mite. Now the last one, that is going to be a rickettsial fever. In the rickettsial fever, we have a first one, that is Rocky Mountain spotted fever. Rocks are hard, so remember vector as a hard tick. Okay, and agent is going to be Rickettsia rickettsii. Agent is going to be Rickettsia rickettsii. Next one, Indian tick typhus. Indians are hard as well, so remember vector as a hard tick for Indian tick typhus as well. And remember the agent is R. coroni. R. coroni. Last one, that is rickettsial pox. The agent is Rickettsia acari, and the vector is mite. So that's all about the disease. That's all about the disease, vectors, and agents at one place. They have asked multiple times. The last previous year question, scrub typhus, sutsugumoshi was asked, louse bite was asked from the Rickettsia prowazaki. That is going to be epidemic typhus. So that completes a final short concise revision for the PSM. So apart from this, even if you have any doubts, you're most welcome to ask. Okay, do focus on the tuberculosis as well, HIV AIDS as well, malaria as well. Okay, questions from them will come for sure from the pharmacological point of view and from the programs that are being initiated. Okay, the calculation, CBR, CDR, IMR, then case fatality rate, then secondary attack rate, relative risk, sensitivity, specificity, and remember also from the Gaussian curve. 1 standard deviation, 2 standard deviation, and 3 standard deviation, 68%, 95%, and 99%. Clear? So those all are important as well. So we are just few days away from the exams. Okay, do not compare yourself with anyone. Whatever you have discussed from, whatever you have studied from last 6 months, whatever you have discussed from last 6 months, whatever mistakes you have done from last 6 months, just analyze those only. Okay, no need to compare yourself, no need to discuss after the paper one. Stick to yourself, believe in yourself, believe in your notes, believe on the teachers, because teachers as well as students, we both have made up an immense efforts, and let's get this exam done. Okay, so God bless you all. Remember, we never lose, we either win or we learn. Take care.